Hey guys, hello, and welcome to the final live stream before the 2023.2 RACGP KFP Exam, and of course AKT for those that are sitting it on the Friday as well. So let's get ready for another session. Good to see so many people in here tonight. Feel free to add any questions, comments, queries, anything into the chat or comments later on. I'll try and get through to everything as well. I've been toying as well with the reply via shorts thing. I've got a couple of little videos out there. So let me know what you thought of that. I don't know if it's going to be an ongoing thing. We'll find out. But of course, enough of the chit chat. We are all here for a purpose, and that is to get ready for the exam. Hopefully your exam prep's going well. We are, of course, 3 days before the KFP exam, and without further ado, now is the time for self-care. So as much as I'm saying get ready for the exam, get prepped and everything, also remember that this is the home stretch and you don't want to hit the exam day burnt to a crisp, not able to do your full potential. So make sure you're looking after yourself, make sure you're getting enough sleep, eat well. From learned experience, don't eat leftovers. You don't want to risk food poisoning or gastro or anything nasty before the exam itself. Make sure if you are kind of hitting it hard and studying right up into the exam that you are taking regular breaks, getting outside, getting a bit of natural light, practice mindfulness. And I was one of those people that always used to think, oh no, that's rubbish, it'll never do anything. It's actually really good. Give it a shot. There's a lot of guided meditations and guided mindfulness exercises available online. Just try them out, see what happens. And of course, avoid cramming, which is just the perfect segue into a live stream going through practice questions. But you know what I'm saying. The reality is this is that home stretch, and so you should have most of the knowledge down pat. This is the time to perhaps refine your technique, but I wouldn't be trying to cram textbooks into your brain at this point in time. So, a final reminder then for answering and formatting your KFP questions. Pardon me. Make sure you are reading the STEM, really kind of going through with a fine-tooth comb, highlighting the key features that are there. This is the key feature exam, so we want to try and pick up on what they all are. Read the question. What is the actual qualifier? Is it the most likely diagnosis? Is it the initial investigations? Because they can have profound impact on the way you would be answering the question. And then what is the action that they're wanting you to take? Have a think through what are the answers that come to your mind immediately, and then try and make sure that you're diversifying. You're not putting everything into a pharmacological or non-pharmacological kind of pathway. You're covering a breadth of different topics, making sure that you're not potentially missing out on marks. When you're actually putting your answers down, then try and be specific and concise. So it's not the example I often use is it's not mastitis, it's acute mastitis of the left breast. Really honing in on exactly what you're talking about. Avoid abbreviations. We've spoken about this before again, but even though it is clinicians marking the exams and a rule of common sense does apply, they can't guarantee that any particular abbreviations would be accepted, and so the blanket rule is just don't use them if you can avoid it. And watch out for overcoding. The no ifs, ands, or buts kind of rule applies. If you're giving more than one kind of statement in a single line or single response, take it out or simplify it down so it's only one response per response. And of course, at the end of that question, once you've got all your answers down, take a breath, take your pulse, move on. Even if you don't feel comfortable with the way you've answered a question, even if you haven't fully answered a question, that's fine. You've got time to go back through at the end of it, to give it another shot, move on. You'll pick up questions, you'll pick up marks elsewhere, and at the end, when you've got a bit of a buffer, go back, go through it all again. All right. One question in the chat already is, are these answers for a future lifestyle management question? Potentially. Are you paying attention? There'll be a question at the end, of course. All right, so coming up to our first question, I do want to just throw into here that there is a trigger warning here. The following question will contain information and discussion around domestic violence, which can be distressing for some people. So if you want to sit this one out, give us about 5 or 6 minutes. We should be through, well, actually probably 10 minutes by the time we go through some of the answers as well. Again, exercise caution, prioritise your mental health and well-being, particularly just before this exam. And if this is something that you think could apply to you, I strongly encourage you to seek out support from your own professionals, your own GP, or some of the health lines or domestic violence advocacy agencies. I've got some of the details there for Lifeline and the National Sexual Assault and Domestic and Family Violence Counselling Line. Okay. Of course, we are getting ready now for our first question for tonight. 2 minutes on the clock, and your time starts now. Janaea Williamson, a 30-year-old Indigenous woman, presents to your rural general practice with multiple injuries, including bruises and lacerations to her face and arms. She appears distressed and hesitant to share information. On examination, there are visible signs of recent injuries on her face and arms. Her vital signs include temperature of 36.9, blood pressure of 130 on 80, heart rate of 92, respiratory rate of 18, and BMI of 26.5. The remainder of her examination is normal. What questions would you ask if you suspect domestic abuse? Provide 3 specific questions. right. How did you all go? Would have been much better if I hadn't gone to write things and not put it on pen mode and instead skip to the answers. But for those that didn't see the answers specifically, so this is taken directly from the RACGP Red Book around domestic violence, and there's actually a specific section around Indigenous domestic violence as well. So some of the recommended questions are, has your partner ever physically threatened or hurt you? And that's taking that direct approach, kind of punching straight to the information you're trying to get. So for that would be with 2 marks. If you wanted to take a more indirect pathway, is there a lot of tension in your relationship? Or how do you resolve arguments in your relationship? Teasing out more, trying to see if they're able and willing to discuss this further. Next step would be to have a soft, direct questioning of sometimes partners react strongly in arguments and use physical force. Is this happening to you? Which again would be 1 mark. Are you afraid of your partner? Would be an indirect marker. And I think that's a particular one that goes well with all the other ones as well, because has your partner ever physically threatened to hurt you is still separate from the are you afraid of your partner, because there can still be other forms of abuse as well. And of course, the acknowledging or allowing to explore through violence is very common in the home. I ask a lot of my patients about it because no one should have to live in fear of their partners. Now, this one is a little bit tricky because it is hard to diversify around the provided answers, but it's teasing through different forms of domestic violence, be it psychological, physical, threatening, or financial as well. And financial is not really covered in here, which probably could be explored. And even though it's not in the recommended answers, I think if you mention something around do you have financial independence, and I can actually see excellent response in there. Someone's popped it in. I think that would definitely get you marks in the actual exam. All right. Otherwise, some fantastic answers there as well, and I think you guys would do well on that one. But of course, the show must go on. Let's get through to the next question then. We'll put 2 minutes on the clock, and the time starts now. On further inquiry, she reveals that she has been experiencing physical violence and abuse within her household. Janaea discloses that her partner has been physically assaulting her regularly, and she feels trapped and scared. She mentions that this has been happening for several months. She denies any history of mental illness or substance abuse. What risk factors can increase the likelihood of family violence in a rural Indigenous community? List 5 specific risk factors. All right, 2 minutes is up. Now, this is one of those questions where they'll feed you a little bit more information, and often they're actually supplying you with hints towards some of the answers there. As I can see, some of you have picked up from the chat. Well done. Again, taking direct from the Indigenous perpetrators of violence, prevalence and risk factors for offending, publication from the Australian government with involvement from RACGP as well. Intergenerational trauma or unresolved historical issues is definitely going to be a factor in terms of the Indigenous rural communities. Persisting racism, ethnocentrism, either way you'd word that. I think if you had any mark that's kind of touching on that aspect, I think it would get you the mark there. Socioeconomic disadvantage, geographic isolation. Again, they've already given you some of the information here in terms of you're in a rural general practice setting. High unemployment rates, substance abuse, alcohol misuse, and I think you would have to be a little bit cautious using both of those answers. I'd probably say there's probably going to have some grouping there, and so given we do have lots of other things we could be choosing, I would probably separate those out or just omit one and focus on other aspects. Limited access to educational opportunities, breakdown of traditional family or community structures, boredom, peer group pressure, and payback against transgressions. So I can see some brilliant answers coming through here. Absolutely smashing it. Low socioeconomic, substance abuse, poor literacy, intergenerational trauma, and stress from financial constraints. Again, we've got access to alcohol. Crowded living conditions would be, I think, community specific, but I dare say in a lot of rural Indigenous communities, you would probably get marked for that one. Financial instability, lack of access to health services, definitely. Lack of access to schooling for children, again, perfect, touching on that educational aspect. And I think that one's a little bit behind. Sorry, that's okay. We will keep moving on. So again, very happy with the answers there. I'm really loving the succinctness, the specificity of the answers, and the diversity in responses as well. So absolutely nailing it tonight. Well done. Of course, we have more questions to go, so let's get to it. Another 2 minutes on the clock, and your time starts now. Janaea is adamant she does not want to involve the police, but has come to the realisation that she immediately wants to leave the house for her safety. There are no children involved. What would be your immediate management for Janaea? List 4 management actions. All right, so 2 minutes is up. And this is sadly one of those things that we often, well, not uncommonly come across in general practice. And working in a rural setting myself, this is something that we deal with on a not infrequent basis. So I think a lot of people would have some experience in here, but similarly though, I think a lot of people could go through their training without having significant exposure to these kinds of presentations. And this is where it can be handy to have a quick flick through some of the guidelines, and I've got a link for those who are interested in that coming up. Now, one of the first traps here is that she's adamant she does not want to involve the police. So any response saying to contact the police or make a police report would not be worth any marks. If that line wasn't there, though, ripe for the picking. And I would actively encourage Janaea to be making a report to the police. So the things that would get you marks, of course, would be ensuring the immediate safety of the patient by assessing the level of risk, That's 2 marks. So that would be checking would the perpetrator, and sorry, I've just made the assumption it's a he, but unfortunately it most commonly is. So would the perpetrator of the violence have a way to track? Would they have access to firearms or means to cause threat to life or limb? Those kinds of questions, and there is a flow chart to kind of step through for this as well. Offering support and referring to a specialised service such as domestic violence support organisation or Indigenous specific services, and exactly what you would answer for that or how you would prefer may differ based on where you are and what services are there. You can list specific services, and I think showing that you know what services are available in your area. The risk you run with that can be if the person marking it's not familiar with that service. However, here, for example, I would be referring to the Mallee Family and Domestic Violence Counselling Service. And so thankfully it's in the name, so it kind of takes some of that ambiguity away. If you are going to specify a service that may have a particular name but doesn't specify exactly what they do, you could put in brackets there domestic counselling service or local support organisation. And that shouldn't give you overcoding. That's more of a clarifying local service. You could leave it generalised and just specify, as it has here, specialised domestic violence organisation. But I think it can show that little bit of polish. It's damned if you do, damned if you don't, unfortunately. And it's one of those things we'll never quite know for sure. It really would come down to the person marking that individual question. Now, of course, liaise with local Indigenous liaison officer, and this would have to be with the patient's consent. Unfortunately, there can be some tricky politics at times in terms of clicks in different services, and so that would be something you would have to explore with the patient directly. Provide a safe environment for open or non-judgmental communication. Document the injuries, and you could refer for forensic examination. This would not necessarily be involving the police. It may be a trip to the emergency department, or in our community, for example, there's one of the general practitioners who is trained in forensic medicine that performs all forensic examinations for the region. Developing a safety plan to address their immediate needs is, of course, definitely something I would be wanting to see there. So, again, some fantastic answers coming up there. So, connecting to the local services, escape plan, non-judgmental approach. Pardon me. Validate her concerns. I think you might be getting a little bit of lack of diversity between validating concerns and non-judgmental approach. I get that they're trying to tackle different things, but I think there's probably other things there that I'd be wanting to tackle preferentially. But certainly as the list is kind of getting a bit longer, it sometimes gets a bit trickier to think of things to put in there. All right. Let's get on to the next question. Oh, before we do, sorry, I did promise you a chart. So this is taken directly from the Abuse and Violence publication from RACGP, which does show a really fantastic outline for approaching domestic violence patients. So again, asking about it, and if they do disclose, you can perform your risk assessment. Children are at risk changes the picture because it's the one time where you may go around the patient's wishes and still make a formal report if there's any concern of the child's well-being. If they say, though, no children in the picture, if they consider they're in immediate danger, then it's a straight referral to police or specialist domestic violence service. Most regions will have a crisis service as well, who do specialise in very quickly and very securely removing victims from this setting. If they declare that they're not in immediate danger, though, then it's accessing other services, if they are or aren't, and getting referrals through in a less urgent manner. Again, if you haven't checked it out, this is the publication to have a look for. Very quick Google will get you there. But of course, today we have... Oh, there we go. If I don't get the transitions mucked up. We have more questions to get through. So, next case with 2 minutes on the clock, and your time starts now. Aisha Khan, a 26-year-old mother, presents to the general practice with a 2-month-old baby, Ali. She reports that Ali has been crying excessively and inconsolably, particularly in the late afternoon and evening. The crying episodes often last for several hours and are accompanied by his face turning red and legs pulling up towards his abdomen. It began at 3 weeks of age and seems to be worsening, not improving. Aisha is concerned that Ali's well-being and feels overwhelmed by his constant crying. Ali is exclusively breastfed, and Aisha reports that he has been feeding well and gaining weight appropriately. He is passing regular bowel motions without evidence of mucus or blood. On examination, Ali appears healthy with normal vital signs. His temperature is 37.2, blood pressure is normal for his age, heart rate 140, respiratory rate is 40, and weight is within the expected range for his age. His abdomen is soft and not obviously tender. What is the most likely diagnosis for Ali's condition based on the given information? Provide 3 specific diagnoses. All right. Now, this is a quite common presentation in general practice. And again, one of those things that sometimes a little bit of life experience also goes a long way. I'm a father of 2. I've got a 5.5, well, almost 5.5-year-old and a almost 2-year-old. And boy, did we go through this period ourselves. So as I can see, people have already put it onto here. Purple crying. Infantile colic or purple crying, interchangeable terms, is the by far most likely diagnosis in this setting. Of course, we would also be considering the non-IgE mediated cow milk or soy protein allergy, lactose overload or malabsorption, gastrointestinal reflux, and you would not get marks here for interception given the duration that it's been going on for. So the interception tends to be that kind of short bursts of crying, followed by relief. And as well as it progresses, of course, as a later sign, you would expect mucousy and bloody stools, and they've kind of gone out of their way here to really push you away from that direction. Likewise, acute infection or illness wouldn't get you any marks, just given the duration here. This has been going on for weeks, and if we're saying it's an acute illness, we'd be expecting that to be a shorter time period. Now, this is all taken directly from the Royal Children's Guidelines for unsettled or crying babies, which I'm sure you have all seen this before. So excellent answers there. And yes, yep, lactose overload, definitely acceptable answer. So very well done. And again, a pretty common presentation and can be really distressing for parents. So a lot of it goes around education and trying to reassure the parents that, you know, time will make things better. But there might be other questions about that. So let's keep going. We'll put 2 minutes on the clock. Your time starts now. You further examine Ali and are confident in your primary diagnosis. You discuss ways to help Ali deal with discomfort and distress. List 4 pieces of advice for Aisha. right, time is up, and I'll just quickly duck back because there was an excellent question there on how does soy protein score here. If you've already got down cow milk protein allergy, I think you would probably have that grouped together with soy, because really you're talking about the non-IgE mediated allergy pathways. And so you could risk it, but I think I would probably try and diversify answers a little bit more. Now, for this question, of course, trying to work out the pieces of advice for Aisha, and probably the most important thing you can do here is to give her permission to rest once a day with someone else to care for the baby. It has gone out of its way to specify that she is feeling overwhelmed. She's in that high-risk period for postnatal depression as well. And if this were a slightly different question, I'd definitely be putting screening for postnatal depression in there, because she's going to be high risk. Sometimes just by giving the parents a recharge, it makes dealing with this situation much, much easier. They're able to then care for Bub a lot more, and kids are very, very clued on. They can sense when their parents are in distress, and that often is something that's going to escalate it. So breaking that cycle is helping sort out the underlying issue as well. Now, of course, in terms of actually settling down the purple crying, one of the most important things to do is try and establish a daytime schedule and routine so that there's a predictable pattern to activities, so they can start to establish their own circadian rhythm, sleeping clock. So that's in terms of feeding, settling, sleeping, and it's a tricky one because it's going to be hard to kind of know if you're potentially overcoding there, and I feel like you could actually very reasonably just leave that bit out, just have establish a daytime schedule for activities, and that would get you the mark. Likewise, establish a routine for putting to sleep, and that's as much having the rituals, so set activities to go to bed, so it's those cues to baby, time for sleep. Avoiding excessive stimulation, in particular in those purple crying periods as well. Darken the bedroom for daytime sleeps. Carry baby in a papoose or front of the chest. Any kind of swaddle will do the trick. Baby massage, rocking, patting to de-escalate. Gentle music. And try to respond before baby is too worked up. And that can be exploring the different cues with the mother as well. So again, some fantastic answers in there. It is all about the daily routine, dark environment for naps, and picking up on those cues. So very well done. All right, we'll put another 2 minutes on the clock, and your time starts now. She is reassured by your advice and is about to leave, when, as they always do, she remembers she had meant to show you a spot she'd noticed on Ali's buttocks. It appeared rapidly 2 weeks ago and seemed to have stopped growing. A photo was shown. What is your single immediate management? List one piece of management. All right, time is up. Let's get to the answers. Oh, I did have a larger version there. Now, this is, of course, infantile hemangioma. a not uncommon. You'll see this from time to time, and it can be really concerning for parents because it can look really sinister. It can look very red, very bright, very angry looking. But thankfully, as you have specified, it is a benign condition usually. There are a couple of things that can happen, and of course, depending on the location, may change your answers here. But a nice benign location like this, it seems to have stopped growing as well. I'd be pretty reassured, and again, I'd be reassuring mum this is a benign condition, and that would get you marks. However, the recommendations currently, though, for these kinds of lesions, if they are in that kind of intermediate risk or low risk, would be to have photo documentation, so monitoring by taking photos from time to time without any risk of complications. Question here about, is this answer from an RACGP exam report? So this one's actually taken, I'm not allowed to officially answer that, but I have had this fed through from people that have been able to help me out with some questions. This is also taken from DermNet as well, in terms of their recommendation is for photo documentation with regular monitoring. And the reason being, we'll skip ahead to here, there can be some complications to them. In terms of they can ulcerate, depending on some locations as well, and parotid being one of the main sites you'd be particularly concerned, they can get particularly nasty and need to have some rather intensive investigations and interventions as well. So if they do become ulcerated, you do have to manage that, and so that for that reason, monitoring is preferred. So being able to provide pain relief, antibiotics for any secondary infections, and because they are so intensely vascular, if they do begin to ulcerate, they can bleed and bleed and bleed and bleed. And so having a plan in place on how to manage those bleeds can be important. Of course, if there's any concerns, it continues to rapidly grow or becomes larger, is in a difficult area, you would consider treatment, and usually the preferred first-line treatment for this would be oral propranolol. It is something, though, that if you have to give a child any medication, can be an interesting affair. And so given the otherwise benign features we've seen from that presentation, I'd be more than happy to continue with photo monitoring. All right, well done, guys, and we are powering through tonight. Hold on, stay with me. You're getting there. You're doing very, very well. Let's put another 2 minutes on the clock for case number 3. Time starts now. Lakshmi is a 55-year-old woman presenting to the general practice for a routine checkup. She has no specific complaints, but mentions she has a family history of bowel cancer. Her mother was diagnosed with bowel cancer at the age of 50. She's never undergone any screening tests for bowel cancer. She denies any significant symptoms such as rectal bleeding or changes in bowel habits. She does not smoke and drinks 2 glasses of red wine most nights. She's had no other medical history and takes no regular medications. On examination, there are no abnormal findings. Her vital signs include a temperature of 36.8, blood pressure of 130/80, heart rate of 75 and a respiratory rate of 16 with a BMI of 26.2. What is the appropriate screening recommendations for Lakshmi based on her family, history and age? Provide one recommendation. All right, time is up, and let's get to some answers. So, if she was under the age of 50, we'd be talking about the FOBTs every 2 years until the age of 50, from 40 to 50. After 50 to 74, 75, you'd be going for colonoscopy every 5 years. And of course, this would be commencing now. So you'd be getting a referral now for colonoscopy and then every 5 years. That would get you the full 2 marks. If you don't specify an age range, then you but specified the colonoscopy every 5 years, you would still get 1 mark there. So excellent. Well done there, Demir. Absolutely nailed it. Just slightly off with the... Oh, no, there we go. We have the correction in place. And yes, 5 yearly colonoscopies. Very well done. Now, I've thrown up here, and feel free to take a screenshot, or I can make this downloadable. This is a summary of the cancer screening recommendations from RACGP. And one of the recommendations through here is an asymptomatic person with 1 first-degree relative diagnosed under the age of 55 puts her into the moderately increased risk category, again with our recommendations in through here. All right. Of course, we have more questions ready to go. So let's put 2 minutes on the clock, and your time starts now. She has a positive result on screening and subsequently returns showing a histology report stating there were 7 adenomatous polyps without evidence of invasive malignancy. She asked what she should do next to help prevent the progression to colorectal cancer. What management actions would you take to decrease her colorectal cancer risk? Give 5 specific management actions. Doses are not required. All right, time is up, and let's get to the answers. So, thankfully, there's actually lots we can do to try and decrease risk of colorectal cancer. Now, number one thing to try and decrease her risk is to repeat the colonoscopy in 12 months. And for that, you would be getting the 2 marks. And the reason for that is the 7 polyps that are in there. That's a lot of polyps. Of course, if it was over 10, you'd be repeating that within 12 months. Under 5, you would be repeating it at the 5-year mark. But in that 5 to 10 range, she's getting another colonoscopy in 12 months, and I would apologise profusely for the bowel prep. Now, next up would be, of course, commencing low-dose aspirin daily for at least 2.5 years until the age of 70. Again, that would give you 2 marks, given it's one of the few interventions we have to directly decrease the risk and has potentially other health benefits as well, which are undergoing further study. If you didn't specify the time frame, even though it hasn't specified dosing, I'd still say the age ranges would be outside of technical dosing, and so you would probably get still a mark, but less marks for that. Provide lifestyle risk factor counselling on the benefits of regular physical activity or exercise would get you a mark. Maintaining healthy weight with a BMI of under 27, and there you'll note we specify maintaining healthy BMI, and so even though she's technically within that criteria at the moment, we would be encouraging the health benefits of maintaining that. Recommending alcohol intake in the low-risk range of no more than 1 drink per day, given she's female. If she was male, we would be looking at 2 drinks per day, which I think is a bit weird. I think it would depend on the size of the person and background. But anyway, I'm getting distracted. Recommend the consumption of vegetables or sources of dairy fibre. I wouldn't be putting both. I'd just be specifying one, but they would be grouped together. So I'll put that there just to simplify it for tonight, as they may be protective. And, of course, recommending only moderate amounts of red meat. Again, grouping. Minimise the consumption of charred and processed meats would also get your mark there. So, very good. I can see some of those answers trickling through. Fantastic. Just to be really nitpicky in terms of... Where are we? The alcohol, I would be saying minimise alcohol intake any further. I would give a specific recommendation, and so actually specifying number of glasses would probably be more likely to secure those marks, but otherwise, fantastic. Again, on that same note, regular follow-up with the specialist for a follow-up. I would be trying to specify timeframes, and so again, saying the 12-month mark for repeat colonoscopy, and I'm always hesitant to say put specialist. I would specify which specialist you're talking about, because it could be general surgeon, could be colorectal surgeon, could be even, depending on where you are, gastroenterologists might be doing the scopes there. So I'd give an actual name, and instead of just saying for follow-up, for repeat colonoscopy. Otherwise, fantastic. Okay, and of course... aspirin daily weight loss aiming to BMI under 25. I will double check the reference I used, but I think they had 27 as their number. Having said that, under 25 would still be a fantastic thing, and I don't know if you would lose any marks for having that. Now the exercise is perfect. Eliminate consumption of processed meat, increase dietary fibre consumption. Nailing it, guys. You are going to be fine and fit for the weekend. Very well done. But of course, get ready. There's more. Time starts now. Given all your recommendations, she is keen to have a care plan made to document and plan these interventions. She's heard from her neighbour with asthma that there are chronic disease or GP management plans and wants to know more information. What are the requirements of a comprehensive chronic disease management plan as per MBS item 721? List 4 required components of the written plan. All right, time is up. And let's get to the answers. Now, this is one of those questions that they can throw at you, and it's a bit of a pain, and it's easy to freak out on the day, but there's good news. These are things you do every day. And so if you ever get stuck in one of these types of questions, just ask yourself, oh, geez, what is on that form? Because that's all you're going to need to put down. You need to document the patient's healthcare needs or problems or relevant conditions, the management goals to which the patient agrees, the actions to be taken, the treatments or services they're going to need, the arrangements for providing these treatments or services, and the arrangement to review that plan by a specified date. And so this is one of those ones that I think we can overthink and spin ourselves out, but just go back to, well, what do I put on the form? And it may be a DVA question, it may be a care plan question, it may be an asthma management plan question. Just picture that form in your head, draw it out if that helps you as well, and think what is there. Now, in terms of eligibility, and you've popped that there as well, you should have chronic condition lasting for at least 6 months. Yes, that is actually definitely true, and I think if you put that down, you would get a mark there. Patient could consent to the preparation of chronic management plan. Yes. I think, though, you would probably lose a bit of specificity in there in terms of she's already come in and saying that she's wanting the plan there. It is, though, if we're being specific, it is a requirement as per the item number. And so, yeah, I think you would get that mark. And that she should be requiring complex care. Technically isn't part of it. There is the requirement to have multiple care providers, but I think you'd potentially miss out on that one. But I can see what you're getting to there, and I think, and yep, you've just popped it into the chat as well. Running out of ideas. Yep. I really like that creativity though. Now, in terms of a new plan can be prepared every 12 months, not actually part of the item description, just kind of a lapsing of it. I don't think you would get a mark for there. Again, I'd probably say go back to what you're writing on the actual forms themselves. But look, a good punt. I liked it. And look, sometimes that's what you got to do. And admittedly, I think you'd get a few marks from there that even though they weren't on this list here, technically were part of the item number. So well done. All right, so that's the end of question 3. But wait, there's more. I figured we're in the crunch time. We're in that last little run. So if you're happy to stick around for a little bit longer, I have prepared a whole new question 4 for you tonight as well, with 3 questions in there. So if you want to get to it, let's put 2 minutes on the clock and prepare ourselves for another round. Time starts now. Emma Wilson, a 25-year-old woman, presents to the general practice with complaints of palpitations. She describes episodes of rapid heartbeats that occur spontaneously and last for a few minutes. She reports occasional lightheadedness during these episodes, but denies any chest pain or shortness of breath. She mentions that her symptoms tend to occur more frequently when she is stressed or anxious. She does not take any regular medications. On examination, her vital signs include a temperature of 36.7, blood pressure of 120/80, heart rate of 95, and I'll change that here, sorry, that is regular, and a respiratory rate of 16. What additional aspects of history could clarify the likely cause of her palpitations, listing 4 on history? All right, time is up, and let's get to it. And so this is taken from the RACGP Approach to Palpitations paper. It was from 2019. I try and avoid references from more than 3 years ago, but there wasn't anything really specifically on this from RACGP themselves, and so I thought this would be the next best thing. Now, they did really focus in on the cardiac aspects, and so the marking rubric here, I think, does have a little bit of flexibility to it if there are questions outside that. But the recommended questions there were, is there any family history of cardiac disease or arrhythmias? That would be grouped together. How frequently is she experiencing palpitations, given they haven't actually said that in the STEM? How quickly do the palpitations come and go? Is it a sudden onset or a gradual onset offset? Is the heart rate regular or irregular? And I do apologise, I'll have to fix this up on future presentations. History of substance use, that would include things like caffeine, alcohol, illicit drugs, and again, they would be grouped together, and so I'd be avoiding putting multiples of that. Has there ever been an associated pre-syncope or syncope? Has she ever had any pre-existing cardiac conditions? Because they haven't specified any history here. And is there any history of sleep apnea? Is there any history or symptoms of thyroid disease? So some excellent ones coming through here. And any heat intolerance, any pedal edema. I would be a little bit, well, actually, no, I see what you're getting at. So first one's getting at thyroid disease. Second one could be a sign of thyroid, more likely to be heart failure. I think that you would be putting down potentially in a 25-year-old who's otherwise well, I would potentially try and source things from elsewhere. Any past history you've got, fantastic. And caffeine intake in a day, very good. Likewise, history of stimulant intake, such as methamphetamines. I really like you're giving a specific example as well and showing that consultant-level knowledge of what the things are that you're looking for. History of congenital heart disease. Oh, chef kiss, perfect. History of menorrhagia, very good. And tying in as well, I won't spoil the fun. And history of hypothyroidism, excellent. Very good. Now, there is a note here in terms of heart rate would not be a history answer, rather a physical exam point. Maybe previously, yes, but this day and age, everyone's wearing some kind of smartwatch or smart device that's measuring heart rate. And I don't know about you guys, but I frequently get people coming in saying, oh, look what my Apple Watch tells me is going on. And so I think it's actually reasonable for a question on palpitations in a young person who potentially could be checking her own pulse as well. I think it is actually fair game to ask about the rate. But just my opinion, I guess. All right. Of course, let's get to it though. We have 2 more questions to get through. So your time starts now. Her symptoms are currently daily to second daily. What initial investigations would be appropriate? Select 6 investigations. All right, time is up, and let's get to the answers. A, B, C, F, K, M, O, and P LFT. Now, these are all the recommended investigations from that paper previously mentioned, and very happy to say you guys have absolutely nailed it. BCFOP, and correcting yourself there for a M. So very, very good. And again, nailing it, ACFMBK. Very well done. Now, I think the thing that kind of seals the deal between a Holter monitor over a continuous loop monitor is the fact that the symptoms are daily to second daily. If they're a bit more spaced out than that, you probably would consider a loop monitor because you're less likely to actually capture one of these events on a Holter. But otherwise, absolutely fantastic. A question in here on what is the relevance of LFTs. So this is starting to come into kind of your hepatopulmonary and circulatory conditions that LFTs are more likely to pick up for if you're having an engorged liver. Excellent question, though. Okay, now coming into, of course, the final question for tonight. Get ready. 2 minutes on the clock and your time starts now. Her investigations all return within normal limits. You're feeling a shift in the local emergency department when you see her. She states she is experiencing her palpitations, which have persisted for 15 minutes. You record an ECG shown below. What management actions would you take? List 4 management actions. All right, time is up and some answers coming through. Very good to see. And I don't know why I can't get rid of that 3 that's there. It's there forever. That's where it lives now. It is our eternal 3. Now, of course, this is a supraventricular tachycardia, or often interchangeably used with atrioventricular AVNRT. Narrow complex tachycardia. It's about 150 beats per minute. There's no visible P waves. We do have some, looking up here, some pseudo R waves as well. But again, if you're picking up there's no P waves, you've got that tachycardia picture. It's saying that the tachycardia is originating from above the bundle of His. There is our answer. How do we manage that? Of course, with lots of toys. And the modified Valsalva. I love it. I've done it plenty of times. I've found it very successful. The statistics say it's just shy of 50% successful. I've probably had better rates of success than that, and so I tend to be, I think, a bit more pro it, but there you go. So this would be where you're thinking through, well, what are the things I need to be doing that safely as well? And so you would be having this patient with continuous cardiac monitoring, frequent blood pressure monitoring, because that's going to tell you if this patient's changed from stable to potentially unstable. Now, the risk of that happening is relatively low, but we're thinking we're going to be bringing out some of our big guns later on, and so we want to be prepared for that. Now, we'll be inserting a large bore IV cannula into a proximal limb location. The answer coming up shortly as to why we're doing that. And one of the interesting things, and I've seen this several times, sometimes the actual shock and pain of having the cannula inserted, particularly if it is a large bore, is enough to give them that little bit of vagal stimulation and can actually resolve the arrhythmia on its own. Take some of the fun out of it, but there you go. The patient feels a bit better. Now, we would then be trying the modified Valsalva maneuver. If you haven't seen or done this yourself, super easy to do. In a GP setting, you could do it quite safely as well. You get a syringe and you basically get the patient to try and blow out on the syringe, have in a semi-recumbent position. Get them to do that for 30 to 45 seconds, as hard as they can. They'll be bright red in the face. You'll see the neck veins distend, and that gives them that vagal stimulation. And as soon as they've kind of met that time frame or about to give up, lay them down flat, lift their legs up to at least 45 degrees and hold it there for about 30 to 45 seconds. I think you tend to get slightly better responses if you leave it for a full minute, but the recommendations are for that 45 seconds. And then you can lay them onto their side, slowly sit them back up again. That's often all you need to do. But of course, if that doesn't work, if you haven't had success with that, you can try and repeat it again, but then we're bringing out the big guns intravenous adenosine, which does have an incredibly short half-life, which is why we insert it through a proximal limb location. You're wanting it right up in the cubital fossa so that it's having a short a path to the heart as possible. So you've got Valsalva maneuver, and perfect. And I like you've kind of questioned there, spelling. That's fine. From that, it's very clear to see exactly what you're wanting. So even if the spelling were incorrect, someone marking that, they've told us many times, they're not worried about spelling. If you can convey the point you're trying to get across, if you can show that you know what you're trying to say, that's sufficient. Now, carotid massage, this is a bit of a tricky one because it really depends on which guidelines you're looking at as to whether or not they're recommended anymore. And so I don't have an official answer from the college, and so I'd be hesitant to say yes or no to that. It's usually the kind of more crumbly patients where there may be carotid plaques. You would definitely be not keen to do that and potentially flick a clot off. Likewise, infants and very young children, it's not recommended anymore as well. And so there is that kind of ambiguity between infant to crumbly adult. So I think I would probably steer clear of that until we did have a proper answer through. Now, prepare for defibrillation if required. I think you could just get away with saying attach cardiac monitoring because I think you would be pretty hard pressed to need defib pads. If anything, you may end up with a bradycardia or look, I think it isn't unreasonable. I don't know if it would get you a mark, to be honest. But adenosine intravenously, yeah, definitely. That'll get it. Cool, okay. And we've got here the vagal maneuvers, adenosine intravenously. If vagal maneuvers fail, perfect. Continuous monitoring, fantastic. Arrange follow-up in 2 or 3 days for further workup of palpitations. Now, you may get marks for that because one of the things that hasn't specified in here, is here. What management actions would you take? It hasn't said immediate management actions, which would necessarily kind of focus you really in on this. I think if there's other things you could put, I'd put that preferentially, but if you're struggling to think of things to say, it may get you a mark. Would referral for electrophysiology study give a mark? Not in this instance. I think that really they're trying to focus in on what are you going to do to address this immediate action. So similar to the last answer there, if there's other things you could put, I'd probably put that preferentially. If it was more of a follow-up type question, then I think you'd be well meant to put it there. And yes, that's true. Wolff Parkinson White can look like SVT. Adenosine will send them into VF as far as you know. Yes, which is why I tried to give you something that was very clear-cut, not Wolff Parkinson White. That was a very, I think, hopefully very clear-cut SVT. So I understand the hesitancy. And look, as I said, I don't know if you would get a mark. It's certainly not a bad idea, and I've seen a lot of places that do put pads on for these things. But in a young female, don't know, can't guarantee, and so I'll just be hesitant to say yes or no to that one. Well done, guys. Absolutely well done. Got to say, absolutely smashing it, and I think everyone's going to be fine for the weekend. Now, there will be one more live stream. Whether you choose to come to it or not, that's fine. I'll be there and talking through... Oh, actually, sorry, I've just seen another quick pop on there. But what to do while waiting, a bit of a debrief. We can't obviously talk through specific questions, but we can perhaps share thoughts around particular themes or topics. Questions come up here. Would I score if I just wrote vagal maneuver, not modified Valsalva? Just forgetting the words. Look, I think you would be risking it a little bit because, again, we're trying to show that consultant level knowledge. You might get a kind of 1 mark rather than 2 marks or a half mark kind of thing, or depending on what your other answers might be, may pull it over the line. I think you're safest putting the actual term. It's similar to that, referral to physiotherapist versus referral to physiotherapist for knee exercises or specifying. Yeah, if you're really stuck and can't think of anything else, by all means put it, but you want to be as precise as you can. If it's a spelling issue, don't worry about the spelling. As long as you're vaguely conveying the message, that'll be fine. All right. So the next live stream will be same time, same place on YouTube, and I'll have the link up before too long as well. Now, again, if you found this helpful, I know that you won't be needing it any further because you're all going to smash the exam, but I'm going to continue this for next round to do another 12 sessions before the next exam as well. So if you know other people that are going to be studying, feel free to spread the word, point it out, and hopefully we can help them as well. Of course, a big thank you for spending such a long chunk of time here. Running through questions late at night, even an extra question thrown in as well. Thank you. Your feedback, your comments, your interactions have made this very, very helpful, worthwhile, and rewarding. So a big thank you there. Now, of course, to end on a celebratory note, I want to say you're all going to be fine. Embrace the challenges, persevere through the obstacles, let your dedication illuminate the path. With a commitment and your thirst for knowledge, you have the power to conquer any exam. Thank you for joining me on this particular journey. And of course, I wish you the very best luck for Friday if you're sitting the AKT, and of course, Saturday for the KFP. For one last time, my name is Kane Treble, and I hope that you remember that generally practicing makes generally perfect. Good night.